So next, the question that you're going to ask now is, when do we refer? Okay, so when do I refer? Okay, so I'm sure most of you all are quite comfortable treating patients with acne, but there'll be at a point where you've given the treatment, or when the patient comes to you with very severe acne, would you want to try the treatment yourself first, or would you want to refer the patient straight away? So these are the questions that you may have. Okay, so hopefully Dr. Evelyn will be able to let us know at which point we should be referring patient. Yes, so without further ado, let me invite Dr. Evelyn again to highlight when should we refer, what are the complications of acne, and when we should refer patients to dermatologists.
Hi, a very good afternoon. Thank you for still staying on with us for this workshop. So I'm going to start my second lecture, which is on complications and referral. Okay. So the learning objectives of this module is firstly to understand the complications related to acne vulgaris, to be able to identify the different types of acne scars, and to outline acne vulgaris cases that needed to be referred. So let's talk about complications of acne vulgaris first. So acne and acne-related complications very frequently have detrimental impacts on patients' quality of life, and very frequently it leads to feelings of embarrassment and low self-esteem. I have so many patients with acne who couldn't even look me in the eye when they come in for a consult. So even when the acne has cleared, the complications that resulted from the acne are still frequently considered cosmetically unacceptable, and they can have lasting impacts on the patients because the complications tend to last a very, very long time. So today we are going to talk on the three most commonest complications amongst patients with acne vulgaris, which is firstly post-acne erythema, secondly post-inflammatory hyperpigmentation, and thirdly acne scarring. So let's talk about post-acne erythema. So it is a very common sequelae of acne. So clinically, it presents as telangiectasia and also erythema post-acne treatment. So you can have a patient who you have cleared the acne, but then it's still left with a lot of erythema behind, okay, even after the acne has cleared. So this is actually a very common cause of distress for patients because because of the redness, right? Even though the patient don't have active acne, but it still gives the impression like the patient still has a face full of acne. So for post-acne erythema, it tends to improve over time, but because it takes so long to actually resolve, it can take weeks to months. Because it takes so long and it's not cosmetically acceptable, so it tends to cause a lot of distress for patients. Next, we have post-inflammatory hyperpigmentation, which is also very commonly seen amongst our acne patients. When I was talking about CAS scoring earlier, I did show you a patient who have mild acne, but yet, still don't look that good because she has a lot of post-inflammatory hyperpigmentation. So the commonest sites of this post-inflammatory hyperpigmentation is usually the cheeks. And again, this is something that lasts for a long period of time. Even, it can last from months to more than a year in more than half of the patients. And because of these dark marks, so it also results in psychosocial impact. And these post-inflammatory hyperpigmentation tend to be tend to be more frequent amongst patients who have darker skin or even patients who have melasma. So moving on, we talk on acne scars. So acne scars can be divided into atrophic scars, hypertrophic scars, and keloid scars. So when you talk about atrophic, as the name implies, it means that these are depressed scars. So there are three subtypes of atrophic scars, which are firstly ice pick scars. Ice pick is where, the edges or the borders of the scar is tapering into a V shape as it goes down into the deep dermis. So box scar is where you see the edges, they are sharply demarcated, whereas rolling is where you see the borders being rolled or sloping. So they are kind of different from your box scars. So ice pick scars are usually quite narrow. These are pictures showing ice pick scars. So they tend to be less than 2 millimeters and they are narrow and they taper as they extend to the deep dermis. Whereas for rolling scars, they are slightly bigger than ice pick scars. They are 4 to 5 millimeters wide. The borders tend to be sloped and they tend to be shallow. And why is it that patient has rolling scar? It's because sometimes when patient develops severe acne, There's very intense inflammation going on in the dermis. So when this inflammation settles, it leaves fibrosis. And fibrosis sometimes will end up pulling the surface of the skin down and therefore leading to this rolling scar. Then we have boxcar. Okay, so boxcar is actually about 1.5 to 4 millimeters wide. They can be round, they can be oval in shape. They have sharply demarcated vertical edges. They can be shallow or they can be deep. So then moving on, we talk about hypertrophic and keloid scars. So hypertrophic and keloid scars has a lot of similarities. They are both raised scars, okay, and they are erythematous. They can be in the form of nodules or in the form of plaques. And in keloid scars, usually the extent of the scar extends beyond the boundaries of the original wound. For instance, you may have a small pimple to begin with, but the keloid scar will extend beyond the boundary of that initial pimple. Whereas if you have a raised scar that is only, arising at the site of that initial injury or the initial pimple, then you call that hypertrophic scars. So hypertrophic or keloid scars or atrophic scars, these are conditions, these are complications that are very, very, very difficult to treat. So even if you have spent tons of money doing lasers, energy-based devices, injections, you can never get perfect skin like how the patient used to have. And that's why we repeatedly stress to everyone that it is still better to treat acne properly than leaving the patient to develop sequelae such as acne scarring. So next we talk about referral. Okay, so just now I think in the question list there was somebody who was asking about referral. So now I have a very structured lecture about referral. So I hope this is helpful for all of you. So in general, the urgency of referral of patients with acne vulgaris can be divided into urgent, which meant the patient should be seen within 24 hours. Seen early, the patient should be seen within 2 weeks, and non-urgent based on available appointment dates. So what are the cases where patients need an urgent referral? So first case would be that if you suspect the patient to have acne fulminans. So this is a patient of mine with acne fulminans. You can see the face looks terrible. Okay, so what is acne fulminans? It is a rare skin disorder in which patients present with acute, painful, ulcerating, and hemorrhagic form of acne. This is not your regular acne. This patient come to me having pus dripping off his face at the first presentation. And a lot of times, patients with acne fulminans also have systemic symptoms such as fever and polyarthritis, and they may also have bone lesions and also laboratory abnormalities. So these kind of cases, you really need to start treatment early. Otherwise, the patients can have very, very severe scarring that tends to be irreversible. So the second group of patients that needed to be referred urgently would be those who have like psychiatric condition, such as major depression or suicidal behavior. So this kind of patient, you need to refer urgently to a psychiatrist for further evaluation and treatment. Then we have the patients that needed to be seen early. So we have the moderate to severe acne, such as those who have nodular cystic acne. So you can see all these big cysts at the back. Okay, so this kind of patient, you can't leave them for a long time. You need to start treatment pretty soon. Otherwise, they would end up having scarring. Or also those patients who have severe social or psychological problems, including those who have morbid fear of deformity, which is also known as dimorphophobia, okay, body dysmorphic disorder. Okay, then we have the non-urgent referrals. So I divide these non-urgent referrals into two groups. First group would be the cases where you have diagnostic uncertainties. For instance, you are not sure whether the patient has acne or the patient has rosacea, or you're not sure whether could the patient be having drug-induced acne and you couldn't seem to find the suspected, the culprit drug. Or if you have patients who you suspect could have, occupational causes of acne, or you think the patient needs underlying endocrinological assessment, or if you suspect the patients may have Staphylococcus folliculitis, Pityrosporum folliculitis, or gram-negative folliculitis, or rare variants of acne, such as acne excoriae, which also frequently leads to scarring, and also chloracne. Then the second group of non-urgent referrals will be those that you think need a dermatologist consultation and services. For instance, those that have failed oral antibiotic therapy, those who seem to have resistance or intolerance to current treatment, those who have scarring or pigmentary changes and is very distressed by it, patients who are pregnant or even, pediatric population with moderate and severe acne vulgaris, or those who have indication for specialized physical treatments such as incision, drainage of cysts, and laser. So I've reached the end of my second talk. The take-home message is this. Acne vulgaris can lead to post-inflammatory erythema, post-inflammatory hyperpigmentation, and also acne scarring. And all these complications can severely affect patients' quality of life. Treatment should be initiated early to reduce these complications, and consider referring patients for further assessment and management if there are diagnostics uncertainties or if patients require specialized care. So with that, I thank you very much.
Thank you very much, Dr. Evelyn. I hope everyone is clear now when to refer patients. Okay, so as you can see, the photos that she had just now, so most of the cases are severe acne or in patients with moderate acne whom you have tried treatment, but it didn't work. So that's the time that the patient should be referred to dermatologists. Okay? I hope also everybody can appreciate the complications from acne. Hence the reason why we are advocating the patients to be treated early, because we want to prevent the complications. Okay? The complications are actually more difficult to manage and they are more expensive to manage. Okay? Laser, okay, chemical peels and all that, it's not cheap. Okay? So hopefully the patients can be treated and referred early.